Hello, my name is Dr. Anthony Caiafa. I'm a senior lecturer at James Cook University in Townsville and also consultant at North Coast Veterinary Specialists and Referral Centre on the Sunshine Coast. The topic for today is dental radiology, tooth resorptions in dogs, and this is presented to you by iM3, the veterinary dental company, which is a well-known veterinary dental company in Australia and also all over the world as well. So currently there is not much known about idiopathic tooth resorptions in dogs. There's very little information in the literature. We don't know the cause, but we do know a little bit about it. We do know that it does occur in middle-aged to older dogs. It seems to affect premolar teeth more than any other teeth, although it can affect other teeth, such as canine teeth. It consists mainly of two types of resorption. One is external replacement resorption, which is a non-inflammatory type. And then we have an inflammatory type or external inflammatory resorption, which usually is associated with inflammation of the gingival tissues at the crestal bone level, so around the cervical area of the tooth, or it can also be associated with pulp necrosis and apical resorption of the root of the tooth. But we can also see it with tumor and cyst invasion. So when tumors or cysts invade the surrounding tissue, they can often resorb tooth structure as well. Currently, intraoral radiography is the only way to diagnose tooth resorptions in dogs and also in cats. So you can see the image on the left-hand side here is a CR7 unit. I'm processing a radiograph. And it is really imperative that we do take intraoral radiography, especially when we're dealing with middle-aged to older animals. There's very little literature on tooth resorptions in dogs. This study out of California, Santiago Peralto, it was a retrospective study. It looked at 224 dogs that were admitted for some form of dental treatment. They did full mouth radiographs on these dogs. These dogs were greater than 1 year of age, and they found about 53% of the dogs had some form of tooth resorption. So it is quite prevalent out there. From that study, they found that about 34% of the resorptions were classified as external replacement resorption. So this is where part of the root is being replaced by bone, and 25% was associated with external inflammatory resorption, and to a lesser extent, external surface resorption occurred in about 4.5% of the teeth examined. They used a classification that is used in human dental literature. The study does highlight the importance of taking full mouth radiographs in middle-aged to older dogs. So from the study, if you look at the page on the left-hand side, external surface resorption, or ESR, can be the earliest sign of tooth resorption. You can see that the periodontal ligament is still intact in this area, but there's loss of tooth structure in the root of this tooth. External replacement resorption could be an extension from surface resorption, where there's actually replacement of more of the root of the tooth, if not the whole root of the tooth, with bone. So it's similar to a type 2 resorption in cats. And then external inflammatory resorption, you can see in this tooth 409, the first molar tooth in the dog, can be associated with pulp necrosis in the dog. So you can see quite a large lytic area here around each root, and loss of tooth structure as well associated with that. But it also can be associated with tooth resorptions, idiopathic tooth resorptions associated with inflammation occurring at the crestal bone level and destruction of tooth structure there. And often with that, you'll see gingival inflammation associated with that. If you look at this radiograph of the left lower quadrant, you can see that we have 2304 here, and there's a number of resorptive lesions occurring here. So we'll go through these. So this is an example of inflammatory resorption. So clinically, you'd see some inflammation in the gingival tissues in this area in 2305. In the next tooth, 306, first of all, we have some fused roots, so it's normally a two-rooted tooth, but you can see there's surface resorption. So the periodontal ligament is intact, but there's resorption of tooth structure there. The next tooth, tooth 307, it has a combination of inflammatory resorption and external root resorption as well. So you can see root resorption or replacement resorption occurring here. But you can also see that there is some resorption occurring at the crestal bone level in the root, and that will be associated with gingival inflammation. When we go to the next tooth, tooth 308, we can see that it's similar to tooth 307. We have a combination of external replacement resorption and also inflammatory resorption here at the cervical area of the tooth, but you can see it's more advanced than tooth 307, where there's nearly complete replacement of the roots by bone. If we look at tooth 309, it actually has apical resorption, so external inflammatory resorption occurring around the roots of the mesial and distal root of 309. So in this situation, all these teeth would need to be extracted. You could save tooth 306, but in the whole scheme of things, you may decide that it's better to be removed, considering that it's undergoing early stages of tooth resorption. Another situation here where we have a clinical photograph, you can see this quadrant 4, and we have the radiograph, corresponding radiograph below. So in this situation, tooth 405 has external replacement resorption, and there could also be some inflammation in this area, although clinically it doesn't look too bad. Again, replacement resorption in 406, 407, 408, but inflammatory resorption occurring on the distal side of 408 here, but also inflammatory resorption associated with pulp necrosis. You can see quite a large lytic area here around the mesial root, and it's also corresponding around the distal root. You can't see the distal root in this situation. So in this case, you would certainly be extracting all those teeth. You can also see that there's a risk here because we have lysis in this area here of the ventral cortex, and there could be a risk of jaw fracture in that area as well. A case where we're seeing inflammatory resorption occurring in the cervical area of a tooth. So if you look at this canine tooth, a clinical photograph, there's inflammation in this area, like pinpoint inflammation. If we raise a small envelope flap, you can see that there's a large resorptive lesion here, and really radiograph shows the extent of the resorption. You can see how large the resorptive lesion here, and this requires that the tooth be extracted because that will be entering the pulpal tissue. Another situation where we have resorption occurring in quadrant 3. Here we have external surface resorption around the distal root of 306. We can also see surface resorption and replacement resorption occurring around 307 and 308. And in this situation, and also we can actually see a root fracture. You can see a little radiolucent line running here, so that would indicate a root fracture. So in this situation, this tooth would need to be extracted. Now, what we don't know is what starts the process, the cause, and we don't know how the process continues. So external surface resorption may be the start of the process, and this can lead to external replacement resorption. That's what we assume is happening. The inflammatory resorption becomes the main component of the disease when we get bacteria involved with the resorption. So when bacteria when the resorptive lesion gets to the crestal bone level in the cervical area of the tooth, oral bacteria can become involved in the situation. But at present, we don't know the cause. We don't really know the process, how this, the pathological process continues. It appears that external resorption process can affect all quadrants eventually, so just be aware of that. Once you see one resorptive lesion, you may have other resorptions occurring, and this is very true for cats as well. Here we have an inflammatory resorption in the crown and cervical area of tooth 308 and 309. 309 here and 308, you can see that there's nearly quite large destruction of the tooth structure here, the blue circle here, and a smaller amount of tooth destruction here in the tooth 309, but with 309 there's actually involvement of the pulp, so we've got some pulp necrosis occurring here, and in this situation we would have to extract both those two teeth. In the 308 case, you may not be able to get the whole root out, but you would attempt to try to get the whole root out if you possibly can. In 309 you would need to get the whole root out. Now, we do know that there are known causes of tooth resorption, so mainly external inflammatory resorption, and we see that with severe periodontitis. We also see that with oral tumours, odontogenic of tooth origin or non-odontogenic, like fibrosarcoma, squamous cell carcinoma, and we also can see that with cysts as well. So you can see in the photograph, the radiograph down here, that this is a tooth resorption. You can see there's resorption of tooth 410 here, and there's resorption, a small resorptive lesion in the root of tooth 409 here. And this was due to a foreign body being stuck in this area for several months, causing tooth resorption. Other known causes of tooth resorptions, this is in A, the radiograph here, this is a plasmacytoma. You can see the amount of resorption, inflammatory resorption occurring here, and also in the mesial roots of this tooth 108. So quite a large, you can see the amount of lysis occurring in the bone. If you look at B here, this is also dentigerous cysts. So you can see the amount of resorption occurring in this canine tooth here. Premolar 1, which was probably going to be causing the dentigerous cyst, has been extracted. You can see the extent of the cystic lesion here. You can see it's also resorbing the mesial root of tooth 406 as well. Now, we do see tooth resorptions in man, so they do occur in man. The causes of them, we can have periapical, which is our inflammatory resorption. They can occur with tumours and cysts, as we mentioned before. Tooth movement in man can also cause tooth resorption. So if you have braces, there's a risk of tooth resorption. Impacted teeth, such as dentigerous cysts, can also cause resorption. And then we do have an idiopathic section as well, as a part of the external resorptions occurring in man. So the same sort of classification that we've been using in dogs is used in man as well. You can see the radiograph and the CT scan on the right-hand side here. Here we have quite a large resorptive lesion in a sizer tooth here. You can see the extent of it. On the CT scan, the cone beam CT, you can see the extent of the lesion here. It's on the lingual side or the palatal side of the tooth. You can see it here as well. Quite an extensive lesion, and an idiopathic cervical resorption occurring there. So the most common cause of inflammatory resorption, external inflammatory resorption in man at least, in the tooth, is due to trauma. And this can be related to earlier trauma, and then years later you can actually see inflammatory resorption occurring in the tooth structure. We don't know if that's a situation in dogs and cats. We're really not certain. You can see another type of inflammatory resorption. This is invasive cervical resorption, which is another type of inflammatory tooth resorption in man, and you can see the extent of the lesion here in this incisor, second incisor tooth, lateral incisor here. You can see the lesion on cone beam here, and it's usually a situation where sometimes we can fill these lesions, but often we've got to consider tooth extraction as a part of the the management of the case. So this appearance is similar to what we see with external inflammatory resorption in dogs and the type 1 lesions in cats. How do we manage idiopathic tooth resorption in dogs, and do we manage it the same way as in cats? At present, there's no consensus amongst veterinary dentists as how to manage these types of resorptions. One of the management issues is we do not know how quickly the tooth resorption progresses in dogs and cats. Hopefully studies will come out looking at the progress of these lesions, but at the moment we don't know. These are my thoughts on, or my guidelines on how we manage these. So if we're dealing with external replacement resorption, if it's in the root of the tooth and more at the apex, then it would be acceptable to radiographically monitor these in practice. When we're dealing with an external inflammatory resorption, or EIR, this usually is associated with either inflammation at the crestal bone level in the tooth, cervical area of the tooth, or associated with pulp necrosis. As I said before, it can be associated with tumors. So the best option here is to extract the tooth. When we have surface resorption, again, as with replacement resorption, monitoring would be acceptable for this, knowing that there's a strong chance that surface resorption can end up being a replacement resorption. Now, we do know that type 1 tooth resorptions in cats has a strong association with periodontal disease, and it is recommended for these dogs as well that an active dental home care plan is put into place, and a daily plan such as toothbrushing or the use of chlorhexidine.